sir. Good morning, all of you. I thank Dr. Arun Garg for giving me this opportunity. Now, this is a very basic presentation. Vertigo is basically a clinical topic. There are absolutely no investigations needed for majority of cases of vertigo. So there are 6 learning objectives at the end of the talk. I hope all of you will be able to address all these questions. What are the 4 categories of neurological disorders that present as dizziness and vertigo? 2 most important histories to differentiate true vertigo from other causes of drowsiness. The nystagmus of posterior canal BPPV, the 2 types of horizontal canal BPPV, the 3 cardinal features of vestibular neuronitis, and how to differentiate vestibular neuronitis from brainstem stroke. Now, the first learning objective is how to differentiate true vertigo from other causes of dizziness. For that, you can understand there are 4 major categories of disorders which present as vertigo or dizziness. Now, this is true for all languages, whether it is Malayalam, Hindi, or English, or any other language. Patients complain of any of these 4 disorders. Patients complain as vertigo. For example, syncope and seizures. Patients say it is vertigo. Many gait disorders like ataxia or subcortical gait disorders or Parkinsonian gait, patients say they have vertigo. Many non-neurological conditions like say anemia, hypotension, cardiac disorders, metabolic abnormalities, fever, all of them patients say vertigo. And finally, there are true vertigo disorders, that is BPPV, vestibular neuronitis, brainstem stroke, vestibular migraine, and Meniere's. These are the 5 commonest vertigo disorders. So how to differentiate all these is actually sometimes very difficult, but 2 most invaluable histories are there. One is loss of consciousness. If loss of consciousness is there, it favors syncope or seizures. Another very invaluable history, which is very not at all asked by many neurologists, but I find it very useful in practice, is to ask the patient whether the vertigo increases when the patient turns to the sides on the bed. So in all these other 2 disorders, gait disorders, if you ask a patient with ataxia whether he is comfortable on the bed turning around, he'll positively say he is comfortable. Similarly, patients with anemia, all systemic disorders, all these patients are absolutely comfortable when they are lying on the bed and turning on the bed. Whereas all vertigo disorders, not only BPPV, all vertigo disorders are to some degree exacerbated when patient turns on the bed. So these are the 2 valuable histories you can ask to differentiate true vertigo and dizziness from other causes of drowsiness. Now, vertigo is defined as to be simple. Vertigo is either a delusion that either the environment is moving or person himself is moving. Now, vertigo is there is this titrate method which is used to diagnose vertigo. Titrate stands for timing, triggers, and targeted eye movement examination, of which the targeted eye movement examination is the most important. So based on the timing, we have acute vertigo, like say vestibular neuronitis and brainstem stroke, or episodic vertigo, Meniere's and migraine, or chronic vestibular disorders like say bilateral vestibular failure or triple PD, etc. And the second thing is triggers, position, whether it aggravates by position, classic for BPPV, whether it aggravates by visual stimulation like migrainous vertigo, or sound, or Valsalva maneuver like say superior semicircular canal descents, etc. Head motion, orthostatic, etc. Targeted eye movement findings are the most important thing. Now, the third and fourth learning objective is the nystagmus of BPPV. So this is the typical case of BPPV. 70-year-old woman with 3 days history of vertigo. Attack occurred first in the morning, and it usually starts when the patient gets up from the bed, and it worsens when the patient lays down back on the bed or rolls on the bed. When she bends over to tie her shoelace, or when she looks up at the ceiling, all changes in position will aggravate BPPV. Now, BPPV there are many subtypes. Posterior canal BPPV is common. Horizontal canal BPPV, geotropic and apogeotropic. These are the 3 common type of BPPV. Now, posterior canal BPPV is diagnosed either by the Dix-Hallpike maneuver or the side-lying maneuver. Now, the Dix-Hallpike maneuver is done by putting the head into 45-degree head-down position, and then to head-down position, and then turning towards that side. This is maneuver for the right side. If you turn to the right side, it is for the right posterior canal. If you turn to the left side, it is for the left posterior canal. Now, third objective is the nystagmus of posterior canal BPPV. Before I play this video, I'll just explain what is happening. In posterior canal BPPV, there's an abnormal stimulation of the posterior canal. So the posterior, suppose that this patient has right posterior canal BPPV. So the right posterior canal activates the right superior oblique and the left inferior rectus. So both these are both these are depressors. So when they depress, the eyes there will be an upbeating nystagmus because the corrective phase will be upbeating. And superior oblique is an intorter and inferior rectus is an extorter. So eye will rotate away from the side of the lesion, but that is a slow phase. The fast phase will be moving towards the right side. So when the patient in this Dix-Hallpike maneuver, if patient is asked to look down at the floor, the right eye will be abducted, left eye will be adducted. So in the abducted position, superior oblique is a pure intorter, and inferior rectus in the left eye is a pure extorter. So the patient will have a nystagmus with fast pace beating towards the right side. When the patient looks at the ceiling, in the adducted position, superior oblique of the right eye is a pure depressor, and inferior rectus of the left eye is a pure depressor. So the fast component will be beating upwards. So the typical nystagmus of posterior canal BPPV is upbeating and rotatory towards the side of the lesion. So the nystagmus will persist only for a few seconds, for some 5 to 10 seconds only, most of the case. Patient looks at the floor, ceiling is purely vertical. This is the classic nystagmus of now that nystagmus. Play the video once again. The nystagmus of BPPV is upbeating. There is also another condition. You can also diagnose by the Simon's diagnostic maneuver. You turn the head to the left side and ask the patient to fall onto the right side. That is a stimulation for the right posterior canal. If you turn the heads to the right side and fall towards the left side, that is a stimulation for the left posterior canal. Now this is the side-lying test. Now, the nystagmus will be same in either it's Dix-Hallpike or Simon. Now patient is turning the head to the right side. There is no nystagmus. Now we turn the head to the left side and patient lies to the right side. That is a test for the right posterior canal. Yeah, now you see the vertical upbeating and lateral nystagmus. Now, there is also a condition called central positional vertigo, where patients may have vertigo and nystagmus when patient lies down from a supine position. But the nystagmus of central positional vertigo is usually downbeating. It's classically seen Chiari malformation. There is, for a typical patient with a posterior canal BPP who has a vertical torsional nystagmus that comes after a latent period of say 10 or 15 seconds, there is no differential diagnosis. So this is one condition in medicine where there is absolutely no differential diagnosis. The classic posterior canal BPPV, there is no differential diagnosis. There is no need for imaging for the classic posterior canal BPPV, whereas if it is geotropic or horizontal canal BPPV, it could still be some other problem. Now, learning objective 4 and 5 are the two types of horizontal canal BPPV. So horizontal canal BPPV is either geotropic when it is due to canalolithiasis or apogeotropic when it is due to cupulolithiasis. It is diagnosed by the supine head roll test. So it's a simple test. You ask turn the head to the right or to the left. So that's also called the head yaw test. This movement to the right or left is also referred to as the yaw plane. So when the patient in geotropic, patient will develop a horizontal beating nystagmus that beats towards the ground. So this is beating towards the left side. after the nystagmus stops, if you turn the head to the other side, then again patient will develop a nystagmus beating towards the ground. So this is called geotropic variant of posterior canal BPPV. Here the whenever, whichever side, if you get more amplitude of the nystagmus when you turn to the right side, it is right horizontal canal geotropic BPV. So the canal which is at fault is at the right side. Whereas in the apogeotropic type, if the nystagmus is more on patient, and when you do the head roll test to the left side, then the right ear is at fault, the upper ear is at fault. So apogeotropic means away from the ground. So this patient's head is turned towards the left side. Now you can have you see the nystagmus which is beating towards the right side, that is away from the ground. The same patient is turned towards the other side. Now you can see the nystagmus beating to the opposite direction. So apogeotropic BPPV, the nystagmus beats away from the ground, and the affected ear is the upper ear. So if you are turning to if you do the head roll test to the right side and get a very prominent apogeotropic nystagmus, the affected ear is the left ear. So how to correct that will be dealt by Dr. Sudhir Kothari. But the decision which ear is affected can be made by the supine head roll test. Now we go to the second condition which is called the acute vestibular syndrome. Here we have vestibular neuronitis and brainstem stroke. Now before we go into that, we will see the learning objective 5 as the 3 cardinal features of vestibular neuronitis. So the first cardinal feature is the nystagmus. So nystagmus of vestibular neuronitis also is very easy to understand. If you stimulate the right ear, the eyes will deviate towards the left side and rotate towards the left side. So the right vestibular nucleus, right vestibular apparatus, if you stimulate, the eyes will deviate towards the left side and rotate towards the left side. So if there is a right vestibular neuronitis, the left vestibular neuron system will overact and the eyes will deviate towards the right side. And the corrective component will be towards the left side. So the vestibular neuronitis, you will have a horizontal rotatory nystagmus beating towards the opposite side. And it obeys Alexander's law, means if a patient has right vestibular neuronitis, the fast phase will be towards the left side. And when the patient looks towards the left side, the nystagmus will get exacerbated, which is called Alexander's law, which is classically obeyed by peripheral vestibular nystagmus. Now towards the left side, you have a horizontal rotatory nystagmus, but on right side, there is no nystagmus. So based on that, you can also grade the nystagmus. If it is there for all 3 directions, it is grade 3. So the nystagmus of vestibular neuronitis, horizontal rotatory, obeys Alexander's law, and it accentuates when fixation is removed. You can accentuate fixation by 3 methods. You can use either a Frenzel or M glasses. You can do an occlusive ophthalmoscopy. I mean, you look into the fundus and ask the patient to cover the eye. So if you are an expert at seeing the eye movements in the fundus, at the optic disc, you can easily see the exacerbation of the nystagmus. Another method which is not popular is the spendlite cover test, means ask the patient to cover one eye. Now you see there is no nystagmus. Now you can remove the fixation by shining a bright light into the other eye. So now fixation is removed, now the nystagmus comes away. So this is called the penlight cover test. So you can remove the fixation by these 3 maneuvers, any of these 3 maneuvers. And nystagmus also accentuates with head shaking, which is very commonly seen. But that accentuation is only for a few seconds.
In the head.
And also accentuates with mastoid vibration, but we will not go into that because of lack of time. Now the second cardinal feature of vestibular neuronitis is the positive head impulse test. Means when you turn the head towards the right side, the right posterior lateral canal will be activated, cause eyes deviate towards the left side. Now you can just see the video. Now this head turn, there is no catch-up saccade. So to the left it is negative. Now you can see the catch-up saccade on turning to the right side. So this is a positive head impulse test towards the right side. The third cardinal feature of vestibular neuronitis is absent or diminished caloric response. If you do a cold caloric test, there will be no nystagmus if the one ear is affected. Now, how the last learning objective is how to differentiate central vertigo, brainstem stroke, from peripheral vertigo, that is vestibular neuronitis. So there are 3 things: head impulse, nystagmus, and test of skew. Now, because of lack of time, I'll just abbreviate here. If head impulse test is positive, it favors peripheral lesion. But at the same time, it may also occur with ICA infarcts at the vestibular root entry zone. But if head impulse test is negative, that favors central lesion. That is the thing which is more important. A positive head impulse test is peripheral, or it could also be central. But head impulse test negative means the problem is central. And nystagmus, if it is unidirectional, it is mostly peripheral, but at the same time, a vestibular root entry zone infarct, like an ICA infarct, may also produce a unidirectional nystagmus. But if the nystagmus is bidirectional, the problem is central. Bidirectional nystagmus cannot be produced by a peripheral vestibular lesion. And test of skew, if it is present, it favors a central lesion. Peripheral vestibular lesion does not produce a positive skew deviation. So these are the three bedside tests by which you can easily differentiate between central and peripheral. Now we'll just see this interesting video.
Test of skew. Perhaps that's going to be abnormal. So what does this look like? So again, to the left, there's a big catch-up. That's a positive head impulse. So if you were to only do the head control, and what does it look like? So this is the same patient who had a positive head impulse.
Sorry. So even if the head impulse test is positive, skew deviation is present, it is a brainstem stroke. So any of these three conditions, if favors central, the problem is central. Now I'll just ask a question. We'll see whether there is something inside this which people cannot comprehend very easily, as you can see from this case. For example, a 30-year-old healthy man presents with a 12-hour history of continuous vertigo, nausea, vomiting, and gait incidents. He prefers not to move his head and is made worse by head movement, including rolling in the bed. That's typical for any vertigo. General neuro examination, gait slightly wide base, cannot tandem walk, otherwise normal. Left beating nystagmus in left gaze. None in primary or right gaze. Otherwise normal, including vestibular reflexes, alignment, and smooth pursuit. So is it central or peripheral? Yeah, I have taught this to many students. Many students cannot comprehend the fact that a negative head impulse test in the situation of acute vestibular syndrome is central thing, because negative head impulse test is otherwise normal. A normal person will have a negative head impulse test. But in the situation of acute vestibular syndrome, if a head impulse test is negative, that means the problem is a stroke. And this patient had a large cerebellar infarct. Now, time is over. The other two vertigo disorders are migraine and Meniere's disease, of which migraine vertigo is incredibly very common disease. It is seen at least 1 to 3% of the population. They have spontaneous episodic vertigo. It's very easy to diagnose. If you have vertigo in a young age, it is most likely migraine. BPPV is uncommon. Okay. So younger the age, more likely it will be migraine. If a child comes with vertigo, it's almost always migraine, not BPPV. BPPV occurs in the elderly. And migraine also has positional aggravation. Migraine also may have tinnitus, oral fullness. But there is another peculiarity of tinnitus of migraine. Tinnitus of migraine tends to be bilateral, unlike Meniere's where it is unilateral. And Meniere's is diagnosed by this triad of episodic vertigo, tinnitus, and sensory neural deafness. That is the key point of Meniere's. Migraine does not have sensory neural deafness. Thank you.